Good morning, everyone. The topic for today's seminar is Gastroesophageal Reflux Disease, its diagnosis and management. We will covering brief introduction about this GERD, its symptomatology, clinical diagnosis and management, including the conservative part, pharmacological part, and the surgical part. Gastroesophageal reflux is the passage of stomach content into the esophagus with or without the accompanied regurgitation or the vomiting. It's a physiological phenomena that occurs throughout the day and night in infants. However, its frequency decreases in the children and the adolescents. There are certain mechanisms in the body which prevent the negative effect of the reflux on the esophagus, which includes the esophageal squamous epithelial layer. Second is the propulsive peristalsis in the esophagus, which causes rapid clearance of this refluxate. And third is the buffering action of the swallowed saliva. Thus, all these mechanisms prevents the negative effect of the reflux into the esophagus. What is gastroesophageal reflux disease or the pathological reflux? It is the reflux that causes troublesome symptoms or leads to the medical complications. Usually in infants, there are a high frequency of reflux that occurs almost up to 3 months of age, with every half of the infant experience once a day. Its frequency is maximum at the age of 4 months of age, and after that onwards it decreases. And almost after 13 to 14 months of age, it completely decreases. And in few cases, like in the cases in which less than 5% cases it persists, it completely disappears by the age of 2 years. Approximately 2 to 7% of the patients of aging 3 to 8 years of age, they have incidence of GERD, and in the adolescent patients, the incidence is of 5 to 8%. Total childhood prevalence of GERD is 1.2 to 3.3%, which is less compared to the adult patient, in which it occurs in up to 5% of the cases. So, for gastroesophageal reflux, there is a barrier, physiological barrier that occurs, which includes the esophagogastric junction. It's a complex system that effectively separates the abdominal compartment with its high pressure from the thoracic compartment with a significantly low pressure. Thereby, it prevents the constant reflux of the stomach from the stomach to the esophagus. It consists of 3 parts. First is the crura of the diaphragmatic hiatus. That is the right side of the crura of the diaphragm. It has an external pinch-cock mechanism that prevents reflux. Second one is the angle of fist. Angle of fist is made between the lateral wall of the esophagus and the greater curvature. And the neonates, it is usually an obtuse angle. When the growth occurs, this angle becomes acute and prevents the reflux. The external angle of fist correlates with the internal flat valve mechanism that helps in the similar thing to prevent the reflux. And the last one is the lower esophageal sphincter, which has its baseline tone that helps in prevention of reflux. This is the diaphragmatic representation of the same. This is the right side of the crura having the pinch-cock effect. This is the angle of the His with the internal gastroesophageal flat valve mechanism, and this is the lower esophageal sphincter with a sling fibers that helps in preventing reflux. This lower esophageal sphincter lies within the diaphragmatic hiatus and forms a tunnel, and this is secured by the phrenoloesophageal membrane. There is a basal tone with a pressure of 12 to 25 mm Hg, and that is similar in the neonates and to the adult population. However, the length of the lower esophageal sphincter varies. In neonates, it is approximately 1 centimeter, and in adults, it reaches up to the 3 centimeter. LES maintains its basic tone. However, it has a specific property that is with the ongoing peristaltic activity of the esophagus, there is transient lower esophageal sphincter relaxation, which lasts usually for 5 to 30 seconds, during which this LES relaxes and reflux occurs. That is the physiological reflexes, and it closes with a brief increase in tone to 35 to 40 mm Hg with the next swallowing effect. So, if the patient is having GERD, they experience more transient lower esophageal sphincter relaxation that last more than 30 seconds. Now, there are certain risk factors for development of GERD in children, and the commonest being include hiatal hernia being the most common risk factor, which are responsible for the development of GERD. Hiatal hernia, including congenital diaphragmatic hernia. It is seen that the survivors of congenital diaphragmatic hernia, 15 to 20% of these cases require further surgery for GERD. Followed by the hiatal hernia is the neurodevelopmental disorders, then cystic fibrosis, epilepsy, congenital esophageal disorders such as TEF or pure esophageal atresia. In the cases of TEF, 30% of these cases will require anti-reflux surgery after repair of their primary defect. Then next comes the asthma prematurity. And in Pediatric patient, it has also been seen that the patients who are obese also have higher tendency to develop GERD, and the patients who are having positive parental history for the GERD, they have again higher risk for development of GERD. Coming to the symptoms, infants and children have different kind of symptoms, and the symptoms are divided into typical and atypical features. Typical features of gastroesophageal reflux in infants include regurgitations and vomiting, and another symptoms include basically the pain caused by the esophagitis that is presented in the form of irritability which occurs during or after feeding, and refusal to feed or failure to thrive, and inconsolable cry. Atypical features of GERD in infants include features of apnea, chronic stridor, wheezing, recurrent pneumonia, hematemesis, neurobehavioral changes, and Sandifer syndrome. Sandifer syndrome is basically a syndrome that occurs lasting for 1 to 3 minutes, during which there is back arching of the body along with the dystonia involving the head and neck, and this spares the limb of the patient. So it is separate from the infantile seizure disorder. Whenever the patient presenting like this, we can have a differential diagnosis of infantile syndrome. However, these kind of features exclude limb movement. So this has to be observed, and it typically occurs at the time of feeding and just immediately after feeding. In children, GERD symptoms include typical features include in children and adolescents. The typical features of GERD correlates with the symptoms in adults, and the most common being the heartburn and chest pain. Another features may include nausea with or without vomiting, pain abdomen, mostly being epigastric, drooling, spitting or water breath, choking during the feeding or night, and poor appetite or refusal to feed. Atypical features include the extraesophageal symptoms, that is chronic cough or recurrent pneumonia, recurrent stridor, bronchospasm, laryngitis, sinusitis, otitis media, gastrointestinal bleeding or anemia due to the erosive esophagitis, dental erosions, halitosis, or the sleep disturbances. There are certain red flag signs in GERD which have some particular differential diagnosis. That is, if any patient is having these kind of features, before attributing these features to the gastroesophageal reflux disease, certain another disease has to be ruled out before considering GERD as a cause for these symptoms. These includes, if the patient is having symptoms within 1 week of age, then congenital GI tract anomalies has to be ruled out along with NEC. If the patient is having forceful vomiting and bilious vomiting, then differentials of pyloric stenosis and intestinal obstruction has to be ruled out. If the patient is having seizures along with hepatosplenomegaly, some metabolic disorders to be ruled out. If there are microcephaly along with dysmorphic features, certain genetic syndromes can be excluded. Macrocephaly and bulging fontanelles are there, then raised ICT features has to be differentiated. If patients are presenting with choking, coughing with feet, then TEF, palatopharyngeal incompetence to be ruled out. If patient is having fever or lethargy, then symptoms, other infections other than the GIT, that is CNS infection and neurosepsis to be ruled out. Certain patients can have a constipation and abdominal distension, in which typical Hirschsprung disease to be ruled out. Abdominal pain and GI bleed can have acid peptic disease, and there are certain behavioral changes, that is rumination syndrome and Munchausen syndrome, that has to be ruled out before considering GERD. Clinical evaluation of the GERD, basically the history and physical examination is the most important thing for diagnosis of GERD. Diagnostic testing is to be kept aside until there are some atypical symptoms or the patient is having refractory GERD, that is not responding to the medical therapy. That after these features are present, then we have to go for diagnostic testing. Otherwise, typical clinical and typical history along with the clinical examination has to be done. Diagnostic testing for GERD includes, first is the 24-hour pH monitoring. 24-hour pH test is the most accurate means of confirming suspected GERD. It's an objective documentation of abnormal esophageal exposure to the reflux acid. It links between the reflux events and the presenting symptoms, and it can tell us about the extent of the esophageal acid exposure. It can be performed by a 24-hour transnasal probe or a small capsules. The capsule has advantage that it can measure the pH for prolonged duration, that is 48 to 72 hours. The parameters which are studied during the 24-hour pH monitoring includes the number of reflexes, that is the pH drops to less than 4 for at least 15 seconds duration, the time required for neutralization of this pH or to increase the pH to 4, that is known as reflux clearance. the number of reflexes with a clearance time of more than 5 minutes, the longest reflex, and the correlation of the intake of food and the time in lying and upright position along with the reflux symptoms. All these parameters studied during the pH monitoring. So during 24-hour pH monitoring, we study the reflux index, which includes the percentage of the time during which the esophageal pH is less than 4. To diagnose it, it has been classified into 3 categories. If the reflux index is more than 7%, it is considered as abnormal. If it is less than 3%, it is considered as normal. And if it is between 3 to 7%, it is considered as equivocal. 24-hour pH monitoring helps to evaluate the relationship between atypical symptoms and the reflux. That is, if a patient is having atypical symptoms at the same time, if the pH is less, then we can correlate that this is because of the reflux of the symptom rather than any other disease. It can also assess the response to the acid suppression therapy. However, there are certain limitations and disadvantages of 24-hour pH monitoring. That is, the severity of the reflux does not correlate well with the severity of the symptoms or the complications or the histology of the esophagitis. Reflux index cannot account for symptomatic non-acidic reflux, weakly acidic, or gas reflux. It can only tell us about the acidic reflux, which is ongoing. However, the patient may be having symptoms due to the non-acidic reflux also, which we are unable to get it from this study. Also, the sensitivity to diagnose the GERD is 41 to 81%, and 24-hour pH testing is required, and sometimes for this, overnight hospitalization may be required. Tracing I'll be discussing in the next 2 slides. Next, diagnostic tests involve the multi-channel intraluminal impedance testing. The overall idea of this test is whenever there is an electric current, there is resistance. So when in the liquid medium, the electric current, the conductivity increases and the resistance decreases. So basically, in multi-channel intraluminal impedance testing, what we do is we place the catheter with a metal probes that detect the change in the impedance when a bolus of liquid or gas passes through the esophagus. We are inserting a catheter with a pH probe along with the metal probe. So whenever there is a bolus, that can be in the antegrade direction in the manner of swallowing, or it can be in the retrograde direction in the form of reflux. That will detect a change in the impedance that will be detected on the tracing of this pH metry. Advantage of this multi-channel intraluminal impedance includes that it can distinguish between the solid, liquid, or gaseous reflex depending on the change in the impedance. It can evaluate relationship between atypical symptoms and the reflex. It can also assess the response to acid suppression therapy. It provides more information than the pH monitoring alone, and some ambulatory devices are also available. However, it has some limitations such as high cost, its availability. 24-hour studies require overnight hospitalization. It requires patient and parents' reliability in documenting symptoms accurately. And it is unclear if it improves the diagnostic accuracy or therapeutic decision-making over pH monitoring alone. Now, these days, pH metry along with multi-channel intraluminal impedance testing is done together, and a single catheter is used to interpret both the things. So this is the device which is used for pH metry as well as impedance calculation. This is the device which is also used in our institute, also in gastroenterology department. This is the data logger and this is the catheter. These are the metallic probes to detect the impedance. There is 2 pH probe, one at the tip and another is at the 15 to 20 centimeter of distance. This is the catheter. First calibration of this catheter is done by putting it first in the acidic solution. We detect the pH over this screen. Then after this, we check the impedance that is also detected on this screen. There are certain buttons on this 1, 2, 3. It is computer-based system and it has a flash card. So basically that flash card is first attached to the computer system. We enter the patient data over it and we ask the patient about the most frequent symptoms that the patient will tell us. We will mark them as 1, 2, 3 on the system. After entering the patient data on the system, we connect the flash card over to this data logger and this catheter is introduced into the patient stomach. Now, after introduction of this into the patient stomach, both the pH probes has to be first inside the stomach, And this monitor will show the pH of 4 or less than 4. That is, both the pH probes are in the stomach. Now we will pull it apart and we'll see the next pH probe that has to be in the esophagus. So the pH value will be more than 4. So we will be able to detect that now our one pH probe is in the stomach and another pH probe is in the esophagus. We will tell the patient about what instruction has to be given. These are certain markers here. When if the patient has started having feeds, then he has to press this button. If the feeds is stopped, then he has to stop this button. If the patient is lying or in the supine position or in the standing position, they has to press every time. And anytime they are feeling the symptoms of GERD, they have to press 1, 2, 3. After this, this has to be given for this has to be done for 24 hours, and after 24 hours, this has to be stopped. This flash card has to be removed and again connected to the computer system, and the tracing will be recorded and that will be read. The tracings are read in the 10 minutes span. Over 24-hour periods, 10 minutes spans will review the slides, and the whole computer-based report is generated, and that gives the final report. These are the tracings. These are the 3 different tracings that tell us about the impedance as well as the pH metry. This is the dotted line is the pH at 4, and these are the impedance tracing. So in the first one, this is the pH and this is the patient tracing, in which initially the patient esophageal probe is having pH of around 6 to 7. Here there is a sudden decrease in the impedance in all the tracings. This is the normal impedance which is going on, and due to some reflux, there is sudden downgrading of this tracing. This is because of the liquid reflux. In the liquid, because conductivity increases, so impedance will decrease, the graph will come down. However, during the same time, the pH is not decreasing. The pH remains the same. It means there is a non-acidic reflux which is ongoing. In the second tracing, here the locations basically multi-channels are used. So in most common being the six channel system. So there are centimeters defined like 4 centimeter, 9 centimeter, 11 centimeter, 17 centimeter. So there are particular distance they are not. Upper esophagus and distal esophagus. Yes. So reflux is mostly upper esophagus. Then in the second tracing, we have seen that this is the pH line. pH is almost near to the 4 or alkaline pH. However, there is a dip in the impedance tracing, that is, there is a liquid reflux. However, in the middle of it, it is again rising and then again falling. So it is a mixed kind of reflux. That is, the patient is having liquid kind of reflux along with gaseous reflux, because after coming down, it is again increasing. Okay, and the reflux, this whole activity is going for around 30 seconds. In the last one, the impedance is gradually rising for the duration for 30 seconds. It is almost a rising trend of the impedance. However, the pH is not changing. It means there is a gaseous reflux which is ongoing. This is another tracing which shows the similar almost finding. The A tracing A, as in which there is pH line at 4. This is the esophageal tracing, in which the pH drifts near to the 4. At the same time, there is fall in the impedance. It means there is a liquid reflux which is ongoing along with some pH which is dropping near to the 4. It means it is weakly acidic reflux which is ongoing. In the second tracing, the pH tracing falls below 0. That is, the pH is decreasing. That is, there is acidic reflux along with impedance is going down. That is, the liquid medium is there. So liquid reflux with a decrease in pH. It means the acidic reflux is ongoing. It's can't go below 0. Yes. In this tracing, the pH is continues to remain more than 4. However, there is dip in the impedance. It means non-acidic reflux is ongoing. And in the last tracing, the pH is going below the 4 and it remains continuous to below 4. However, the impedance is initially going down and in the middle it is increasing. It means there is mixed reflux or superimposed reflux, that is liquid reflux along with the gaseous reflux as well. Now coming to the next modality, that is the endoscopy with biopsy. Endoscopy is best method for detection of esophagitis that occurs as a consequence of GERD. However, in 60 to 80% of the children, there is normal study. And if the endoscopic study is normal, it does not rule out that GERD is absent. This kind of GERD is known as non-erosive reflux disease. It can identify complications of GERD such as reflux esophagitis, Barrett esophagus, esophageal adenocarcinoma. It can also assess the response to acid suppression therapy and useful in dysphagia and odynophagia. There are certain findings which include such as this appears as a normal esophageal mucosa, the mild erythema is there, and a moderate thickening, erythema is there, and severe erosive disease is found out. There are certain endoscopy, when combined with the biopsy, it increases the diagnostic accuracy. However, it cannot determine whether the non-acidic reflux is occurring or not. Endoscopic and histological findings in GERD are non-specific and they correlate poorly with the symptom severity. And there is associated procedural and sedation risk. There are certain scoring systems for esophagitis that has been defined. First include the Savary-Miller interpretation, in which esophagitis has been characterized into 4 grades. Grade 1 includes erythema, grade 2 includes non-circular linear ulceration, grade 3 includes confluent ulceration, and grade 4 includes the stricture. The more commonly used classification system includes the Los Angeles classification of reflux esophagitis, in which esophagitis has been graded into 4 categories, grade A, B, C, D. In A, there is mucosal breaks of less than 5 mm. More than 1 break can be there. However, they are not meeting at their junction. In grade B, mucosal breaks are there of more than 5 mm. However, the tops of the mucosal folds does not meet. In grade C, 1 or more of the mucosal breaks occurs of more than 5 mm, and there is a mucosal continuity of the breach. However, it involves less than 75% of the esophageal circumference, and in the grade D, more than 75% of esophageal circumference is included. Coming to the next modality, that includes the barium upper GI studies. It identifies the reflex regardless of its pH, mostly used for anatomical causes of GERD, such as esophageal web, stricture, TEF, intestinal atresia, achalasia, pyloric stenosis, malnutrition. All these features can be identified. It can also identify the aspiration, which is related to the reflux. Motility disorders can be identified. It is less invasive and routinely available. However, it has poor sensitivity and specificity for GERD, and findings do not correlate well with the severity of the symptoms or histological findings, and there is associated radiation exposure. Coming to the next modality, which is the nuclear scintigraphy. It's a technetium-labeled milk scan. It's a non-invasive test. Basically, a technetium-labeled sulfur colloid is mixed with the milk, and it is fed to the patient. Half of the feed, the technetium-labeled sulfur colloid is added, and in the another half of the feed, cold feed is given. And after feeding the child, the patient is kept on the table with a gamma camera beneath, and films are taken over a duration of 1 to 2 hours. It is particularly done in the situations such as recurrent pneumonia due to the aspiration of the gastric content. Nuclear scintigraphy can identify reflux regardless of its pH, can identify aspiration related to the reflux, and delayed gastric emptying. However, it again has poor sensitivity, that is 15 to 59%, as compared to pH monitoring alone in diagnosis GERD. It lacks standardized method of interpretation and cannot identify late postprandial reflux or reflux independent of eating. This is the image of one scintigraphy in which sequential 5-second frames of multiple episodes of long-lasting reflux has been detected. This is the stomach, and this is the marker for mouth. And they have seen that we have seen that reflux is occurring in the esophagus more than the mid esophagus. Like length of the reflux is beyond the mid esophagus. Interpretation varies. Some may say that the reflux which is lasting for less than 10 seconds or more than 10 seconds, or it is high grade, low grade, based on the length of the esophagus over which reflux is occurring. So if it is occurring more than half of the mid esophagus, then it is considered as high grade. If it is occurring low, then it is considered as low grade. Manometry, it measures the mechanism of swallowing. However, it has less role in confirming GERD. Identify transient lower esophageal sphincter refluxes, useful in diagnosing motility disorders and achalasia. However, it cannot predict response to medical and surgical therapy. It has minimal role in diagnosing GERD. Now comes the infant GER questionnaire. This is basically a reflux symptoms based scale that has to be filled by the caregiver. There are certain questions and the maximum total score includes the 25. If the score is more than 7, then the sensitivity of 74% and the specificity of 94% is there for the diagnosis of GERD. However, its utility in the developing countries is not been established. It is used as a screening system for GERD in developed countries. Coming to the Rome third criteria to diagnose GERD, it includes all of the following in a healthy infants of age 3 weeks to 12 months of age. Includes there are regurgitation that has to be present 2 or more times a day, lasting for 3 or more weeks, and there should not be any retching, hematomesis, aspiration, apnea, failure to thrive, feeding or swelling difficulties, or abnormal posturing. If these features are there, then we can suspect a patient to be having GERD. सर ये बेसिकली फिजियोलॉजिकल रिफ्लेक्स को बता रहा है सर, नॉट दी पैथोलॉजिकल.
You should say that this is for physiological.
So for defining physiological GER in infants.
Yes. This is the diagnostic approach. It is published by the SGPGI Lucknow that I have taken this approach from that paper. In the infants, they have described that if any patient who is having features of GER, history and physical examination is done, and if any warning signs are present that I have mentioned before, then further evaluation has to be done as per the clinical symptoms. If there are no warning signs and there are signs of complicated GER disease, then they has to be further evaluated by pediatric GI consultation. If there are no complicated signs of GER, only physiological GER is there, then these children are labeled as happy spitter. Then no investigations to be needed further, parental counseling to be done. Any warning signals has to be watched for, and modifications can be done in the form of frequent and low volume feed. Optional include formula feed that can be thickened. Usually symptoms resolve by 18 months of age. If it does not get resolved, then further evaluation has to be done.
फिजियोलॉजिकल वाला क्राइटेरिया को दोबारा लाओ. इसमें ऐसे क्यों कह रहा है? It has to be 2 or more times per day. अगर 10 होगा तो 10 हो जाएगा. कुछ और है ऐसा मतलब
मैं एक बार देख लूँ. In older children and adolescents, if typical reflux symptoms of heartburn are present, then again history and physical examination to be done. Initially, a conservative therapy to be considered that includes the lifestyle modifications such as weight reduction if the patient is obese, alcohol and smoking has to be avoided, and PPI proton pump inhibitor has to be given for 2 to 4 weeks. If there is improvement occurs, then PPI has to be continued for 2 to 3 months and again taper off in next 2 to 4 months. If relapses is not there, then the further patient has to be observed. If after lifestyle modification there is no improvement, then patient has to be referred to gastroenterologist for further evaluation.
Is a major problem.
I understand your totally difference.
Now moving on to the management of GERD. As you all know, and as been previously described, the lower esophageal sphincter has 2 main components. One is the intrinsic component and one is the extrinsic component. The intrinsic component primarily comprises of both the circular tonically contracted muscles, which form the clasp muscle fiber, and the diagonally oriented sling muscle fibers, which can be seen here. These are the clasp fibers and these are the sling fibers. Contraction of these lead to prevention of the reflux or the tonically contracted state of LES. The extrinsic component of the lower esophageal sphincter comprises of the crural fibers at the esophageal hiatus of the diaphragm, leading to the pinch cough mechanism. The lower esophageal sphincter is primarily located in the esophageal hiatus, and the normal length is expected to be around 2 to 4 centimeters. The normal resting pressure is around 20 millimeters of mercury, and it can vary between a range of 15 to 29. Half of this functional high pressure zone is present above the diaphragm level, and half of it is below. It is fixed at this position by the presence of the phrenicoesophageal ligament, which is a continuation of the transverse fascia of the diaphragm, and it has two leaves. The thin lower leaf attaches to the esophageal wall at the angle of phase, and the upper thicker collagenous leaf is a continuation with the outer or the collagenous extension of the esophageal wall itself. Initially, we'll consider the medical management of patients with GERD. This includes the initial anti-GER measures, which are informed or told to the caregivers. This includes prone positioning with the trunk raised. This has been described as the most effective mechanism because the height is at the highest position during this positioning. However, there is risk of sudden infant death, and obviously difficult for the caregivers to manage the patient in this way. Thus, supine position with the trunk elevated or left-sided positioning for older children during sleep, and the elevation of the head or the propped up position of the bed is the preferred modality. Frequent small volume of meals can be considered, and thickening of the meals can also be considered. Apart from this, various head. The trunk elevated, yeah. Supine position with trunk.
Body,
Upper toe. I meant upper toe. Coming to the various medical modalities which can be used, these include use of antacids, which can buffer the gastric acid and neutralize the gastric pH of the reflux. Then we have surface protective agents such as sucralfate, which can create a barrier which impedes the acid peptic injury caused by the GER itself. Then primarily used or the most commonly used modality is the use of PPIs such as Pantop and Omaze, which inhibit the potassium and hydrogen ATPase inhibitor, and the antihistaminic drugs such as ranitidine, which block the H2 blockers. PPIs are the most commonly or the predominantly used medical management in patients with GERD. Probiotics also have some role as they can maintain the gut homeostasis by modulating the intestinal barrier function, improve the immunity, improve the gut motility, and influence the gut and the gut interaction. Apart from this, certain prokinetics are also advised in patients with GERD. These include drugs such as domperidone, metoclopramide, baclofen, and cisapride. Cisapride was predominantly used drug initially and extensively studied. However, due to its cardiac toxicity in the form of prolonged QTs, it is no longer recommended to be used in patients with GERD, especially infants. Currently, the most common ban is
Locomide is supposedly banned.
Initially they described that initially cisapride was used, now we don't use it anymore. Currently, the most commonly used drugs are metoclopramide and domperidone, which both help in enhancing the lower esophageal tone and improving the gastric empty, and thus decrease the reflux. Now, considering when are we supposed to consider that now this patient can all be managed by medical management and we need to proceed with surgical management or consider surgery in these patients. These would include patients who have episodes of recurrent aspiration and pneumonia, patients who have had apneic episodes, bradycardia, or acute life-threatening events, patients who have failure to thrive, esophagitis, development of strictures, multiple episodes of severe vomiting, and also to be considered in patients who have failed medical management in terms of poor compliance, or these patients have special conditions such as neurological impairment, patients with TEP, patients with CDH, or anti-abdominal defects, in which reflux is more common, and we likely think that this will not respond spontaneously with medical management only per se. As per various studies, surgical management is deemed to be superior to medical management, and however, initial medical management trial is given, but conclusively, various studies have concluded that surgical management, whether by an open or laparoscopic approach, is superior in the treatment of GERD. There are various kinds of surgeries which have been defined for GERD. These include Nissens, Toupets, Thal, and Dors, which fundoplication, which, as you can see in Nissens, there is a 360-degree wrap. In Toupets, there is a 270-degree posterior wrap, and in Thal, there is an anterior 270-degree wrap. Both the approach. नहीं, मैंने उल्टा बोल दिया. Both the approaches have been defined, that is the open and the laparoscopic approach. If we are going by an open approach, it's an open upper midline laparotomy incision. If we are considering a laparoscopy or a minimal invasive approach, the commonly used position is a supine position with low lithotomy, or a French position might be considered in older patients, in which the surgeon stands between the legs of the patient, and a reverse trunnion position might be used so that the viscera falls away from our area of interest. The most commonly used ports or the port placement is as shown. This is the supramuscular cavernous port, and these are two surgeon, the working ports for the surgeon. The port for liver retraction can be placed. There are various preferences. Certain people tend to insert the retractor in the epigastrium. However, we can also insert it in the anterior axillary line over here. And an assistant port is also used for retraction purposes. Moving on with the first technique, that is the distance fundoplication. This begins with incision of the gastroesophageal ligament, primarily in the pars flaccida region, that is the avascular portion, till we can visualize the right crust of the diaphragm. After this, we incise the peritoneum between the right crust and the esophagus and try to create a plane between them interiorly, except towards the gastroesophageal junction. After this, the peritoneum over the anterior esophagus is elevated off, and we have to be very careful during this because the anterior vagus branch of the anterior branch of the vagus is right there, and while exposing the left crust of the diaphragm, we might injure the same. Then we try to create a plane between the esophagus and the left crust. Division of short gastric vessels is classically described in the original technique. However, there is discrepancy regarding this. Some people believe that if we can have adequate mobilization, we might not actually require division of the short gastric vessels also. But some argue that for complete and adequate mobilization, that has to be done. After this, we do blunt dissection in order to create, develop the retroesophageal space. Again, we have to be cautious not to injure the posterior branch of the vagus in this. After this, we've completely encircled the freed esophagus. We move on with the closure of the pleural defects, which has to be done under minimal tension. Along with this, two collar sutures were placed at 4 o'clock and 8 o'clock respectively. That is between the esophagus and the hiatus. Then the greater curvature of the fundus is passed through the posterior esophageal window behind the lower esophagus. After this, we use the shoe shine maneuver to ensure that our fundoplication is loose, floppy, and symmetric. After this, we approximate the fundus around the esophagus using interrupted sutures. And after this, the completed fundoplication would look like something like this. And an endoscopic evaluation can also be done to ensure that the fundoplication is adequate.
One important step is
The wrap migration data.
और एक तो मैं बताया कि वो उसी से किया
There are various complications associated with fundoplication. Intraoperative complications can include esophageal or gastric perforations during the time of mobilization, injury to the vagus nerve, as described previously, pneumothorax due to hiatal dissection. And postoperative complications include dysphagia, which might require esophageal dilation due to eventual development of strictures, retching if the wrap is too tight. Gastroparesis, development of pneumonia, wrap herniation, development of hiatal hernia, dehiscence of the fundoplication per se, and eventual development of recurrent GERD due to failure of the surgery itself. Gas and bloat syndromes are extremely common in patients with distance fundoplication, and this is the advocate for which people propose that instead of doing a complete 360-degree fundoplication, we should consider partial fundoplication because of the excessive tightening of the fundus. The rate of recurrent GERD can be is seen in both laparoscopic and open approaches, with a higher incidence of around 7% in the open approach. That is what the propose.
मुझे नंबर दे दिया था मैंने कंपेयर दिस टाइम now number this time.
Another additional part of Nissen's fundoplication is Foley's gastroplasty. It can be an uncut Foley's gastroplasty or it can be a Foley's Nissen's fundoplication. The primary indication of doing a Foley's gastroplasty is a foreshortened esophagus, in which we suspect that because the length of the intra-abdominal esophagus is small, therefore there is risk that there will be recurrent transdiaphragmatic herniation of the same. Therefore, we create a new esophagus from the tubularized portion of the stomach itself. Two approaches can be used for the same. Primarily, we insert a dilator into the stomach along the lesser curvature, as we can see in this cut section. Then the angle of the endoscopic esophageal stapling device is passed through the posterior surface of the stomach through the anterior surface. Here we can see that we have come from the posterior surface towards the anterior surface, creating this window, gastric window. Then we use stapler, insert the stapler into this and fire it in order to create a deploy it parallel to it, as we can see in the image. And this will be our eventual staple length. If we just staple it and leave it, it is uncut Foley's. However, if we further proceed with the fundoplication, it becomes Nissen's Foley's fundoplication. Another thing of doing the same gastroplasty is doing a wedge gastroplasty. In this, a triangle wedge of the fundus is cut at the angle of his, and it is excised using a linear stapler to divide the stomach from the apex of the fundus. As you can see, over here we've used the stapler, and this is the apex of the fundus. And then we use this another stapler and we fire it like this so that we create a new esophagus and we create the angle of his as well. Yes.
इसमें फंडोप्लाइकेशन क्या इसोफेगस पर तो लाइन इंक्रीज करनी है उसका फंडोप्लाइकेशन इससे क्या है सेम स्टमक से
So it's would difficult है नहीं
only length of esophagus
length increase करने के लिए correct है इसमें उन्होंने क्या किया. Moving on to the other kind of fundoplication, that is the two-phase fundoplication or the posterior partial fundoplication. Again, the patient position is similar as in Nissen's fundoplication, and the port placement in this is that we use, these are the two working ports. This is the camera port and this is the retractor port, again subject to the surgeon's preference. Again, in this, the lesser sac is open and the plane between the right truss of the diaphragm and the esophagus is developed. After this, the retroesophageal space is developed, ensuring that we don't injure the posterior vagus nerve. The basic principle is same as the Nissen's fundoplication. In the traditionally described two-phase procedure, the short gastric vessels were spared and the esophagus is spared on the and freed on the right side anteriorly and on the left side. After sufficient mobilization such that we have around 4 to 5 centimeters of the stomach mobilized, lower esophagus mobilized, we then pull the anterior wall of the fundus behind the abdominal esophagus and wrap it and hold it in place with a frame stitch. This is the frame stitch which we initially take. After this, we proceed with hytoplasty, that is closure of the diaphragmatic hiatus, so closure of the approximation of the pleura. After this, we proceed with the valve attachment, in which the right part of the wrap is stitched to the right crus initially. The next suture is then taken such that the right part of the wrap is then stitched to the right anterior wall of the esophagus. The first stitch was between the lower esophagus and the pleura. The second stitch is between this wrap and the lower esophagus. Now, 3 stitches are placed between the gastric fundus to the left. This was done on the right side. Now we're moving on towards the left side and the left anterior wall of the esophagus. The wrap is done such that the anterior 90 degrees or the anterior 90 degree surface is free. After ensuring this, we remove the initial frame stitch which we had taken so that our wrap does not migrate. Postoperative complications primarily involved in toupee are the slipping of the valve, which causes recurrent GERD. This is the most commonly encountered one. The advantage of this over Nissen's or a complete fundoplication is that since it's a partial fundoplication, patient can still have maintain the ability to bench. In the classically described two-phase procedure, they did not divide the short gastric vessels. And and since we are doing a partial fundoplication, we can prevent a tight wrap around the esophagus. This is primarily or commonly used in patients who have esophageal motility disorders such as atresia in order to prevent the outlet obstruction. The other described technique is Tharal's fundoplication. Again, the patient positioning or the OT setup is similar to both the previously described surgeries. However, the port placement over here is more similar to the Nissen's fundoplication. This is the camera port. These are the two working ports, and this is the assistant port. Or third is the retraction port. And port 2 is can be used either as the camera port or can be used as the assistant port, depending on the surgeon preference. In Thar's fundoplication, initially we begin with the esophageal ligament, which is cut, and again adequate mobilization of esophagus is done. Now the next step is to do narrowing of the hiatus behind the esophagus, that is the hytoplasty. After this, one row of 3 non-absorbable sutures is placed between the anterior wall of the fundus and the esophagus. As we can see, this is the anterior wall of the fundus, and this is the esophagus, and we place 3 sutures like that. Then a second row of 3 sutures is fixed to the anterior wall of the fundus, to the uppermost part of the intra-abdominal esophagus, and to the edge of hiatus. That is, in the first step, we are bringing the wrap over the esophagus, and in the second step, we take sutures from this wrap to the hiatus. Over here, we can begin this initial dissection. We can identify the anterior vagus over here. After this, we can identify the hiatus. And over here, we have completely mobilized the esophagus. After this, we have taken the close the hiatus using the initial hytoplasty suture. And after this, we take the first row of sutures, that is, take the wrap over the lower esophageal segment. And in the second layer of 3 sutures, we bring this wrap further forward and suture it to the crus itself. Apart from these described surgical techniques, there are other techniques for further management of GERD patients. One of the less commonly practiced ones is the endoluminal radiofrequency application. In this, a catheter is passed orally into the distal esophagus, and the balloon is expanded, and the electrodes pierce into the esophageal submucosa. Then the radiofrequency energy is used, and the subsequent tissue reaction leads to the contraction of the distal esophagus and thus augments the lower esophageal sphincter. The mechanism by which this works is poorly understood, and the results across various trials have been conflicting, hence it's not very predominantly used. Another recently described modality is a transoral incisionless fundoplication. It was first described in 2008, in which we created a neo-gastroesophageal valve. We create serosa to serosa plications, as we can see in the image, and include the muscle lift to construct valves, which are around 270 to 300 degrees in circumference, and ideally, this should be 3 centimeters long. This is done by deploying multiple non-absorbable polypropylene fasteners through the esophageal and the gastric layers into a circumferential pattern around the gastroesophageal junction. Now focusing on GER and TEF.
Devices.
Moving on to the role of GER in TEF, since TEF is the most commonly encountered surgical indication for us, and the incidence of GER in these patients is around 20 to 60%. There are various mechanisms in which patients with TEF are more prone to develop GER and GERD, leading to requirement of surgical intervention. These include first, the excessive tension at the initial anastomotic site. This leads to lower or decreased tone of the lower esophageal sphincter, shortening of the intra-abdominal length of the esophagus per se, and also deformity of the cardio-esophageal junction. Secondly, these patients have tendency of abnormal esophageal motility per se, thus the reduction of contents from the esophagus is decreased, and the time required for this bolus to transit is longer. Thus, these patients are prone to GER. Again, these patients have slower gastric emptying, there's abnormal gastric myocardial activity, and also sometimes in patients in which we are not doing primary anastomosis, we tend to do an esophagostomy and gastrostomy. Doing this gastrostomy can per se worsen the GER and the effects of GER. Complications which are most commonly noted in patients with TEF can be divided into short-term and long-term complications. In short-term complications, anastomotic stenosis, peptic esophagitis, feeding difficulties can be noted. And in long-term complications, recurrent anastomotic stenosis due to persistent reflux, bronchial hyperactivity due to aspiration issues, and development of Barrett esophagus and esophageal adenocarcinoma can also be seen. Though esophageal adenocarcinoma have been documented in 3 cases, but they're rarely seen in our pediatric population. So what would be the recommendations in for patients with TEF who come to us with GER? As we know, they are prone to GER. First would be to treat all these patients with acid suppression in the from the neonatal period itself. That is, whenever we do a TEF surgery, we send them off on Pantop and all the anti-GER measures.
Last time discussing AIIMS protocol, we should not be taking this. We are repeating what we discussed in last segment. And when this people start eating to all their parents, there is no evidence. Unless I'm good person.
PPIs are the first-line therapy for all these patients, and we should be treating all these patients systemically for prevention of peptic complications. All esophageal atresia patients, including the asymptomatic patients, should undergo monitoring of GER via the various modalities such as impedance, pH monitoring, or endoscopy at the time of discontinuation of antacid treatment, or in the follow-up period. You have to do this at least once. Severe esophageal dysmotility predisposes patients with with esophageal atresia to post-fundoplication complications as well. However, patients in esophageal atresia, they benefit from fundoplication, especially in patients who have recurrent anastomotic strictures, especially in long gap esophageal atresia patients, patients with poorly controlled GERD despite being on maximal PPI therapy, long-term dependency on transpyloric feeding through the transanastomotic tubes, or patients who have, again, dying spells or the acute or adverse transient life-threatening events. The incidence of esophagitis and esophageal gastric and intestinal metaplasia, that is Barrett's esophagus, are increased in adult patients who had esophageal atresia and were surgically treated for the same. Thus, regular clinical follow-up in every adult patient with esophageal atresia is recommended, and we have to specially refer to presence of dysphagia, presence of any GER, respiratory symptoms, or anemia. It is recommended that we should follow them up with routine endoscopies, with biopsies in all 4 quadrants at the gastroesophageal junction, and also at the anastomotic site at the time of transition into adulthood, and then once every 5 to 10 years. Additional endoscopy can be considered if these patients have any worsening of symptoms or any new additional symptoms develop. And in Barrett's esophagus also, the same has been recommended.